There we go. I'm sharing my screen. Can everyone hear me? Okay, I got no audio, but I'll just go ahead and talk and I'll monitor the chat. Thank you so much for the opportunity to be here. My name is Pete Campbell. I live in Oregon, which is not too far away, but so sorry I couldn't be there in person. And thanks for the really nice introduction. As it was mentioned, I work with a large group in the IROP Research Consortium, which I had the privilege of leading, but it was really started by Mike Chang, who's now the director of the National Eye Institute in Bethesda, and it was a good mentor, an amazing mentor and good friend. These are our funding disclosures, and I'll be talking about a lot of different applications of artificial intelligence in the disease I focus on, which is retinopathy prematurity. We are trying to bring those to the market to make them usable, not just academic projects, but actually useful products at the bedside. And so I do have financial interest, and so I want to disclose that. To lay the context for this disease, and I'll talk a little bit more about the disease in a sec, but this is Core Stadium in Denver, Colorado, and it seats about 50,000 people. And that's how many babies a year go blind around the world from this disease called retinopathy prematurity. This is Army Harper, who I stole this slide analogy from. He's a retina specialist in Austin, Texas, who's focused on addressing this problem as well. But the key thing is that nearly all of these cases are preventable. That is, if we had systems in place to identify and treat these babies, it wouldn't have to be like this. So when we talk about prevention, I have a master's degree in public health, which means I know enough public health to be dangerous. But what I remember is that there's different levels of prevention. There's primary prevention, secondary prevention, and tertiary prevention. And for ROP, each of those has unique implications. And AI actually has potential applications in each of them as well. Let me talk a little bit about the disease. So ROP is a disease that is caused by our successes in medicine. That is, it's a disease that didn't exist 100 years ago when premature babies died. But in the mid 20th century, as neonatal care improved, we pediatricians started saving the lives of these preemies, and a generation of kids went blind. Stevie Wonder is an example of that first epidemic of blindness. And clinicians over the next 20, 30 years realized if we could balance oxygen exposure, we could dramatically reduce the incidence of ROP. And so the numbers went way down just by improving neonatal care. That's primary prevention of ROP. Secondary prevention is identifying the disease in the at-risk population. And as the limit of mortality started going younger and younger and younger, now we're keeping babies alive at 23, 24 weeks gestation, they remain at risk for ROP. And so it's our job as ophthalmology team working with neonatology team to identify them. We do those through eye exams, basically. And if we identify babies at the right time and we refer them to treatment, that's sort of tertiary prevention, we can usually prevent blindness. There's now a so-called third epidemic, and some people say fourth epidemic, going on around the world, which is a mix of the first and second. That is, as neonatal care is improving in parts of the world, Eastern Europe, East and South Asia, Sub-Saharan Africa, babies are surviving, but aren't necessarily able to have the resources to titrate and monitor oxygen. So the population at risk is higher again. And these are regions that have an order of magnitude or two orders of magnitude fewer ophthalmology resources. And so there's an epidemic of blindness around the world related to this disease epidemiology. So I'm going to cover all three of these and how AI may play a role in them. But I'm going to start with secondary prevention because that's the most obvious application in medical imaging of AI for disease detection, for example. And there's great examples. For example, if you know anything about ophthalmology and artificial intelligence, the first autonomous algorithm for detecting a disease in all of medicine was approved in ophthalmology, and that was for detection of diabetic retinopathy, which is a leading cause of blindness among working age people around the world. We evaluated whether if you took a picture of a baby's eye, you could diagnose a certain component of ROP called plus disease. And this was a paper we published in 2018 in JAMA Ophthalmology and showed that taking an image using a UNet, as was just described in the prior talk, to segment the blood vessels, and then analyzing the blood vessels, you can get an output that diagnoses plus disease. And it showed that that could happen more consistently than with the average expert. we then converted that because it turns out plus disease, which is this degree of dilation and tortuosity of the blood vessels, is a spectrum. It's not like it's there or it's not. There's degrees of it. And so we converted the output of normal, pre, plus, and plus, which is an ordinal scale, into a continuous scale. And so the algorithm actually now outputs a number. And it turns out that that concept of moving from a classification label to a continuous output is quite powerful. And I'll show you a couple of applications of that. Turns out that the degree of dilation and tortuosity is a surrogate for the overall level of ROP in an eye. So if you can focus your attention on these box plots here, these were 5,000 different eye exams, roughly 5,000 different eye exams with consensus standard, reference standard diagnosis, multiple graders on images, and a bedside examination. And all of those led to these ordinal categories of no ROP all the way up through treatment ROP or treatment ROP with aggressive ROP. That's sort of the most aggressive. And it turns out that the 1 to 9 output, which is based on a single photograph, like shown on the bottom, is a very close surrogate for the overall level of disease. That is, if your number is a 1 or a 2, you have very, very low likelihood of having severe disease. And if your number is above a 5 or a 6 or a 7, you're very likely to have severe ROP. We further showed that using that as a surrogate for disease, you could notice changes in disease severity over time. And that's what this violin plot in the upper right shows. Eyes that progress to treatment in the 2 darker shades, and eyes that progress to treatment with aggressive ROP, which is again the most aggressive, happens fastest and the earliest, and you can't miss it. We could identify disease progression over time. So at a single point in time, you could have a good surrogate of the overall level of disease, and following over time, you could identify disease progression. And so the natural question is, can we use this to autonomously detect ROP in regions of the world where you may not have enough examiners? And from an academic perspective, the short answer is yes. We've published 4 papers on the left, and there's 2 papers that are in process that are sort of the largest that have shown in every population we've looked at, essentially, using this concept of plus disease as a surrogate for the overall level of ROP, we can identify severe ROP in every case with 100% sensitivity with moderate degrees of specificity depending on the populations. But the idea is, if you could develop the infrastructure, if you could have the algorithm at the bedside, if you could have all of those pieces, which is the big if, and this is where the realm of implementation science plays a role, in theory, this technology could work to screen for ROP. But even more than that, it's not just you screen for ROP one time. It's something that you have to do again and again and again until the baby's no longer at risk. And in that violin plot I showed you earlier, this is sort of a different summary of the same data. We noticed that the curves in terms of where the babies were progressing started separating at 32 or 33 weeks post-menstrual age, which is about a month before most of these kids ended up being treated. And so we said, well, could we use this to help improve specificity of screening criteria so that we could do fewer exams, also subject babies to less stress, because these exams are quite stressful, as I know several of the other speakers come from a neonatology or pediatrics background, they know. Could we use this to identify early disease progression in complement with existing clinical risk factors, like how early the baby was born, to take a population where in general, only 10%, 5 to 10% of a screening population will end up needing to be treated, to a population where you do far fewer normal exams without missing any severe exams. And so this was work done by my colleague in Oregon, Aaron Coiner. We developed a logistic regression model using 2 simple variables. So this is an interpretable model, gestational age, plus the score that I showed you based on a single photograph. And that single photograph was taken at 32 or 33 weeks, whichever was available earlier. And again, using these different models, we evaluated on two separate populations. One was sort of a multi-center academic population in the US, and one was a community hospital. And in both cases, based on a single exam, we could rule in or rule out high risk or low risk disease. And in the low risk group, if you were never looked at again, none of those babies developed severe ROP. And in the high risk group, you could follow them very, very closely, reducing the risk of missing aggressive ROP, which again can progress over a few weeks' time. And so in theory, again, from an academic perspective, this concept works. That is, could we use this to reduce the number of screening exams and improve early diagnosis in patients progressing to severe ROP? But the question is, I showed you that the large majority of the patients going blind actually go blind around the world, where these resources may not exist and where the demographics are different. And so the question is, would this work in low-income country populations? And so we did something similar. We have a good collaboration with the Irvine Eye Hospital in South India. We had 2 years of consecutive data. Every patient screened by their telemedicine system is roughly 5,000 exams. And we trained a different model, not using 32, 33 weeks as a time point, because demographics there are a little different, but using the first exam, which tended to be at 2 to 3 weeks of life or prior to discharge. So same idea, gestational age of birth plus one image from one time point. And we tested it on 3 separate populations, 6 months of unseen data in India, a data set from Nepal, and a data set from Mongolia. And again, in all 3 cases, we didn't miss any babies progressing to severe ROP. And in all 3 cases, we identified the highest risk babies up to a month before treatment. So in theory, again, in this population too, it could work to, again, early diagnosis, reducing low risk exams, improving sort of resource utilization, and in that population where it's sort of most needed. So in summary, for secondary prevention, there are a number of different potential use cases for artificial intelligence. It could improve efficiency, objectivity, and accuracy of the clinical examination. One thing I didn't talk about in this talk, just because there's not enough time, is subjectivity of diagnosis and inter-observer variability is a big problem. Happy to talk through that in the Q&A session. But part of our, in fact, primary motivation for the start of this work was actually to address that issue in terms of providing objective diagnosis of ROP. It could also provide earlier diagnosis of severe ROP, including aggressive or aggressive posterior ROP. And in theory, it could reduce the number of exams required, including in the LMIC population, which is a big part of my effort in trying to bring this technology to the bedside. I'm going to shift to tertiary prevention. So tertiary prevention is consistent treatment and identification of complications. I showed you that the number, that vascular severity score that we call it, is a good surrogate for overall level of disease. And so we looked at babies in our data set. This is roughly 200 babies or something like that, where we monitored them the weeks before and the weeks after treatment. Time 0 is the time that they were treated, and saw that, sure enough, we saw babies progress before treatment to the highest point when they were treated, and go down afterwards. But this oversimplifies the story, because there's different ways to treat babies, and using the quantitative metrics that these algorithms provide actually help us learn something about that. So I'm not going to get too much into the weeds here, because this is not an ophthalmology audience, but suffice it to say, there's advantages and disadvantages to the different treatment modalities in terms of which babies benefit from one versus the other and how quickly they respond. And we've been able to use this to help parse out some of those data. For example, a big problem is if laser sometimes requires more than one treatment. And those babies are at the highest risk of developing retinal detachment and blindness. And we showed retrospectively that babies that failed initial treatment actually had higher vascular severity at baseline, suggesting that either they had more severe disease, maybe they were treated later, or more posterior disease. And this sort of gets beyond maybe this audience, but long story short, we could potentially use a score like this to provide objective diagnosis to help clinicians make more informed treatment decisions as to the risks and benefits and potential outcomes of different treatments. There's been a big shift in the past 10 years towards the use of pharmacotherapeutic medications and anti-vascular endothelial growth factor, anti-VEGF medications. One of the problems for those medications is that once you treat, the disease goes away, which is remarkable, and the vessels can continue to grow, but sometimes it reactivates, and you have to be able to find that. This was work we did in collaboration with the group published the CARE-ROP randomized controlled trial, and this was work recently published where we showed that monitoring post-treatment using images, we could identify babies who were reactivating and in need of additional treatment. This was all done after the fact. So these babies, these time points where there's arrows, those were time points when the clinician, that point in time, decided this baby needed to be treated. Subsequently, we went back and ran the analysis on it and showed that the algorithm conformed to clinical diagnosis, suggesting that we may be able to use this to help identify, again, reducing the number of exams for low-risk babies and without missing severe disease. I'm just going to move on from this point. I alluded to this earlier, that subjectivity and accuracy is a problem. These are data from our group. This is 11 different investigators. This is the degree of vascular severity at which 11 different investigators diagnosed what we call plus disease and chose to treat a baby. And we've anecdotally observed that there's differences among a population in terms of how severe some people let an eye get before they treat. But with this, we were able to show that there's differences not only between examiners, and examiner I here is clearly an outlier who treats at a lower level of severity than the rest of the group. But even within examiners, examiner E had a fairly wide variety, a wide spectrum at which he would sometimes call plus disease and treat, suggesting that perhaps he was incorporating other clinical factors into the clinical diagnosis, and others who were very, very, very strict. They waited until the blood vessels got very, very dilated, very, very tortuous, and that's when they would diagnose and treat. And this heterogeneity is a problem because without objective diagnosis, this problem exists in all of our clinical trials and leads to inconsistent treatment and practice. So using something like this in clinical trials, we could help address this problem in the future. So for tertiary prevention, consistent treatment and identification of complications, AI-assisted diagnosis could provide objective treatment thresholds and standardized treatment between clinicians. This would require prospective research. Identify treatment failure and reactivation, I sort of alluded to that. And in theory, help us determine the most appropriate timing and or method of treatment to improve outcomes. And so lastly, I'm going to move towards primary prevention, which is, to be honest, the most important, because as I showed you with the first epidemic of ROP, the first epidemic of ROP, so-called quote unquote, ended just with improvements in neonatal care. And around the world, if 50,000 babies are going blind, the vast majority of those are going blind in low-income countries, and largely due to two problems. One is, in many cases, unfiltered access to oxygen, where they don't have appropriate blenders or they don't have appropriate ability to monitor that, and not enough ophthalmologists to be able to screen that entire population. And so the question is, is there an application where we could use this technology to help monitor, improve outcomes to reduce the population at risk? Why is this a big deal? So on the left is a plot of the number of premature babies born around the world. And so the first problem is that the number of babies born premature is an order of magnitude higher in certain parts of the world, sub-Saharan Africa and South Asia in particular. And if you look at the shades of blue, preterm babies 32 to 37 weeks in these light blue boxes, those babies in the US and in Western Europe and in parts of Asia are not at risk for ROP. With optimal neonatal care, we don't even screen for babies older than 32 weeks because the risk is essentially zero. That's not the case in many low-middle-income countries, again, because of the oxygen story. And so you have more at-risk babies, and it's exponentially more because the older babies are at risk. And again, these are regions that have fewer clinicians. And so this creates a perfect storm for this so-called third epidemic of ROP, which in theory, we can prevent. So, sorry, that slide had a, I'm going to stop for 1 sec. That slide had audio on it. Apologize about that. I'm going to go back here. So what we did was I showed you that AI that applying the vascular severity score to a baby gave a surrogate for the overall level of disease in a baby. Well, if you take the 10 babies in a NICU, 20 babies in a NICU, you do that for the NICU, you can overall get a level of ROP in that entire NICU. And so what we did a few years ago was said, hey, we're part of this telemedicine program in South India, where anecdotally they came to, my colleagues there said, we have outliers. We have NICUs that have really, really, really severe ROP and others that basically have none. And so we said, can we measure that using images? That is, look at all the images of babies in a given NICU and say, can we determine that there's differences? And the answer was yes. So if we look at these NICUs, hospital 10 versus hospital 11, for example, hospital 10 on the top had the lowest overall severity score. That is the summation of all of the individual babies within that NICU. And the hospital on the bottom had the highest. But this was not explained by demographics. That is, the hospital at the bottom actually had older and bigger babies, which should have a lower risk of ROP, but that's not what we found. What we found was that the differences between these hospitals were explained by access to pulse oxygenation and oxygen blenders. That is, we found a statistically significant difference in the level of ROP as measured by AI in hospitals that had access to the right resources versus those that didn't. Recently, we went back and looked. So in the red is the data set from 2015 to 2017, and in the sort of teal is 2019, 2020. And what we've seen is that these are districts, so not NICUs. These are districts within that region in South India. And we found over this 5-year period, there was actually a significant reduction in, and these are birth weight and gestational age matched babies. There was a significant reduction in moderate and severe ROP within the same region in South India that we could assess just by clinical diagnosis on the top, and we could see using, again, this sort of district level severity score on the bottom. And these differences strongly suggest that primary prevention is improving in this region, and that it happens coincidental with this ability to do telemedicine and the ability for sort of one team to help improve education throughout the region. And so from a ROP specialist perspective focused on global health, this is actually a really, really exciting finding, because it suggests that this problem is solvable, and we're seeing it improve even in a relatively short period of time. And so for primary prevention, again, improved oxygen monitoring, population level assessment could contribute to a better understanding of ROP epidemiology. It could help target outlying NICUs for intervention. It could lead to reduction in the population at risk and incidence and severity of severe ROP. And it could, in theory, contribute to the end of the third epidemic of ROP. And so as I close, I mentioned primary, secondary, and tertiary prevention. And I mentioned some potential roles of artificial intelligence in all of these levels. I'm severely glossing over the implementation challenges and the regulatory challenges because each of these represent different indications for use and different regulatory pathways. And there's obviously lots we can discuss there. But from a 30,000-foot view perspective, the idea of moving from subjective to objective, from qualitative to quantitative, and using AI to provide a surrogate level of severity has multiple potential applications in this one disease, and that's representative of many other diseases within ophthalmology and perhaps outside of that. So we're hoping that the future of ROP blindness looks more like this, where Denver Stadium, or Core Stadium in Denver, is empty. And that's what Paul Chan, my colleague in Chicago, what Mike and all of us are trying to do through this work. So I'll stop there. I'd love to chat, and thank you so much for the opportunity. I have no audio to the room at the moment.
Or is it?
I had it for a second, then it cut out.
Yeah. Dr. Campbell, can you hear us now?
Can you hear us now? Yep. Can you hear us? I could hear that with an echo, but I could, if you asked a question that way, I could try and answer it.
Okay. All right. So, questions, hands. Was he really that convincing? Ah, Chun, one of the unconvinced.
I'm not unconvinced, but I just have a question about what you said about the subjectivity of ROP diagnosis. Is there currently standards that are accepted internationally for this diagnosis? And do you think it could be improved to help with the subjectivity that you discussed?
Yeah, that's a great question. So there was a process that happened about 2 years ago called the International Classification of ROP, and it was the third iteration of that classification. For the first time, so the classification was defined in the 1980s and then was updated in 2005, and then it was updated again in 2020. And for the first time, that classification acknowledged this problem, which is that there's a subjectivity, and addressed the problem without a solution by simply saying that plus disease, that part of the disease that I mentioned, presents along a spectrum, and some people have different cut points for addressing it. So there are standard photographs. There have been standard photographs for the level of disease that have been part of the classification since the 1980s. But until we had regular image-based documentation, which happened about 10 or 15 years ago, we didn't understand the scope of the problem. And it took about 10 years for the classification system to finally acknowledge that it's a problem. And actually mentioned, Mike Chang, who's my mentor, was the head of that committee. And so it's actually an interesting discussion to go read. But technologies like this could help address that problem in the future. So the long answer is yes, there's a international classification, there's photos, but despite that, even among the members of the committee, we wrote this up last year, there was a significant variability in terms of among the world experts in terms of their clinical diagnosis.
Hello. Thank you for your answer, Dr. Campbell. I actually have another question, but I would like someone else to take a turn if anyone else has a question. Okay. So since you mentioned that there is disagreement among the standards for classifying ROP, how do you assess the accuracy of the ROP diagnosis by the artificial intelligence? And are there like many different standards for assessing the accuracy, and how well do they agree with each other?
Yeah, these are really insightful questions. So because that was the motivation for the work that led to all of the downstream things that I talked about, and Mike being a sort of informatics trained person, this was sort of front and foremost for how this algorithm was trained. And that is, it was trained using I alluded to this, but it was trained using a reference standard diagnosis. So that process involved 3 separate masked graders applying a diagnosis to images and images from the clinical exam of whoever was participating on that day. So that led to 4 labels. When those 4 labels agreed, easy. When they didn't, they took the majority. And if there was a 2-2 split between those 4 labels, they all convened and came up with a consensus, not just for plus, but for the other aspects of the disease, zone, stage, plus, and overall category. And that was what was used to train the algorithm. And so this is a little bit of a circularity, but when we then evaluated the algorithm against initially 8 international experts on an unseen data set, we asked 8 international experts to label plus disease, and then we had the algorithm label plus disease. Using the reference standard label for that data set, again, unseen data, the algorithm performed better than 7 out of those 8 experts. That's not to say that those experts were wrong, because as I alluded to, there's really no definition of right and wrong here. And even more complicated than that, and again, this is all stuff I just didn't have time to go into, there's evidence that cut point for where the average clinician might change from a, say, moderate to severe level of disease might be earlier now than it was 10 years ago. And so even our clinical trials, which use this language, may be less meaningful now because the interpretation of that language might have changed. And so these are really fundamental questions that are important for us as a community to answer. But without either a reading center telling clinicians what to do, which is really hard to do in this disease because babies need to be treated really quickly, or without some sort of objective diagnosis, it's really hard to do.
Thank you for your answer, Dr. Campbell, and also thank you for your talk. I found it really fascinating.
Thank you so much.